So today we will the core of presentation will be first I'll give an introduction, then the concept of healthcare finance, context of healthcare finance in India, timeline of healthcare financing in India, and a recommendation and references. I'm not going to give a SWOT analysis. SWOT means strength, weakness, opportunity, and threat analysis of each insurance policies, etc. But I'm not going to do that. So not boring you much. This is why this topic is important. Last day my son just had an accident. He drank the mosquito repellent unknowingly, accidentally, and he was admitted in ICU 5 days, 7 days ICU, and he was admitted in Jubilee and 7 days. The bill was 35,000, and the question comes: who will pay the bill? That will be that introductive question from my part. Who should pay the bill? We may think you can, from a broader perspective, you can say as a father you have to pay, or as a family has to pay, or the country needs to pay. Since he is a citizen of India, state should pay. So this question is the basis for healthcare financing. Whenever I pay it, it is called health expenditure, or we call this when I pay or the country pays, it is called the health expenditure. Health expenditure on an accident, how it affects, who will pay, and how now India is paying for the health expenditure. So we will go through that, and I will give you will get an idea on the way. So this will help you why India is after Ayush doctors. I was also very much against Ayush doctors, but after reading the documents, the treatment plans, I have a different opinions. Still in a controversy, so I'm not commenting on that. But since I am politically oriented, I have my own opinions. So there is a shift, major shift from a UPA government to Modi government too. So we have to think in that way also. So this part of healthcare financing is something interesting. So this will be the base. Who recommended it? The Board Committee report in 1946 says, no individual shall fail to secure adequate medical care because of the inability to pay for it. So this is the base of healthcare financing. And how we will achieve in at least, let's say 2026, how can we achieve this? So that is the base. So let me go to the next. In this, a microcosm of all the healthcare system in the world. You know, the healthcare system can be different, as you have seen, different in America, it is different. In if you are asking in Canada, you may be heard of NHS in UK. So we can call it as Bismarck model, Beveridge model, Douglas model, and the last one is out of pocket. In Bismarck model, the private insurance, the citizen or the employer pay for your the insurance, and the provider, that means the hospital, will be private hospital. That is Bismarck model. This model is followed by Germany, USA, Netherlands, and Switzerland. Whereas in Beveridge model, who is paying the insurance? That is government, and who is giving through the citizen pays through the tax payments. For example, in NHS, the UK, the people pays a lot of tax, and government is giving them insurance, and the service is provided by public, maybe private, some private, but mostly public. Public is given such as in Britain, Cuba, Spain, and mostly private in the sense Denmark, New Zealand. And Douglas model, government is running the insurance, citizen is giving a premium, and the provider will be private hospitals. This is happening in Canada, Taiwan, South Korea. In India, who will pay? Citizen is paying for his own health. Who is financing his own health? In India, it is citizen. And the provider can be public or private. This is the predominant model in India, but still we have all models in India. Okay, I hope you got something. So India is a microcosm of all the healthcare system in the world. But India has a different approach. The paradox, we can say, hello?
Yes, sir, it's audible. It's okay.
Yeah. Okay. So India is towards quality at an affordable cost. So I'm going to give you a different perspective towards India's health system. India has high quality clinical outcomes at affordable cost. Still, the cost maximum for the 5 days of or 7 days of an expert treatment for my son costs only 35,000 in India. If it is in USA, it will be 10 times greater than India. And India has 37 Joint Commission International Accredited Hospital and 513 National Accreditation Board for Hospital Healthcare Providers Accredited Hospital, which next to 514 will be Jubilee in very soon. And cost of treatment is less than 1/10 in comparison to the USA. And clinical outcomes in leading hospitals, the treatment is the value or the outcome of the treatment in Jubilee is equally good, especially if you can say in our gynecology department, all if it is equally comparable to the internationally recognized facilities. And we are promoting another a new thing. This is what I was saying about in the introduction: alternative medicine and rejuvenation therapies. Modi government is bringing about a new theme called health and wellness. For example, the treatment of other ailments. So this brings people from the other countries to India as medical tourism for medical tourism. The visas nearly 5 lakh visas were last year was issued for the medical tourism itself. So there is a new brand this government is bringing of. That means if you are coming with for your ailment for cancer or palliative treatment, here you will have a better treatment, like you will have wellness treatment, you will have nutrition, you will have yoga. So this is the new brand, like Chinese building up on their acupuncture. So it is important in a new perspective of Indian government. So now we come to the topic universal health coverage. In the world, 100 million people are pushed into the extreme poverty due to the health expenditure. 930 million people, that is 12% of the world's population, spend at least 10% of their household budgets to pay for healthcare. All UN member states have agreed to try to achieve universal health coverage, including India, by 2030 as a part of Sustainable Development Goal. And Sustainable Development Goal 3 is regarding health. And on that, the 8.2 is about universal health coverage. So universal health coverage requires a strengthening of health systems. And for that health system, you need robust financing structures. That is the key towards achieving this universal health coverage. Universal health coverage emphasizes not what services are covered, but also how they are funded, managed, and delivered. So these all are important when you think about in terms of WHO. So we can go. So that is the part. That is the as an introduction part. Then I come to the definition. When I come to the definition, according to WHO, what is the definition? Healthcare financing is defined as function of health system. It's a function of health system concerned with accumulation, the three things: accumulation, mobilization, and allocation of money to cover the health needs of the people individually and collectively in the health system. So, okay, it's a definition. So what did it mean by that? What is the purpose? Purpose of healthcare financing is to ensure that all individuals have access to effective public health as well as personal health care, to make the funding available, to set the right financial incentives for the providers. So goal of the health will be to raise sufficient funds for health in a way that allows people to use limited services. Excuse me.
Veni, can you please switch off your mic?
Should I continue or? Okay, the goal of healthcare financing, like to raise sufficient funds, obvious, to raise sufficient funds in a way that allows people to use needed services without the risk of severe financial hardship. Then when they use it, we call it as financial catastrophe or impoverishment. Because as example I told, the last expense, sudden expense for me was 35,000 for an expenditure for my son's treatment, and my salary is only about 45,000 per month. So if I use suddenly, if I don't have a backup, if I don't have enough backup, I would have gone to impoverishment or my other needs will suffer. So this is about the goal of healthcare financing is not risking the financial hardship. So objectives will be to raise sufficient funds, and second will be to provide financial risk protection to the people, and third is efficiency in the utilization of the resources. How we can achieve these objectives, that we will be the next. So based on these objectives, we have three functions. First is revenue collection, second is fund pooling or we call it as risk pooling, third is purchasing or provision of services. So how we can collect revenue? There are different types of collecting the revenue. First will be tax revenue, income tax, service tax, or non-tax revenue such as tolls, what we call palliative tolls. The government can apply the cess on the petrol, or capital receipt, that is selling their companies such as BSNL, they can bring the money on that, or externally such as for US aid, ADB, Asian Development Bank grants can be given through the government alone. So what do you mean by next function is, as we told, fund or risk pooling. Risk pooling is the spreading of financial risk associated with the need to use and pay for health services rather than to be fully borne by the individual who falls ill. There is a solidarity between the ill and the health. The health is also sharing the risk. Healthy is sharing the risk with the ill who is ill. So there is, as a country, is helping a person to overcome his illness. So this risk is pooled, risk is shared, and the financial risk associated with the need to use and pay for health service are shared. Pools can be compulsory, automatic, or voluntary participation. Compulsory participation is by legal requirement with contributory based entitlement, like means if you are employed in a company, you should pay for it. That is compulsory. Or automatic is non-contributory, deriving from citizenship, that is residence or other factors such as whether you pay or not. You will be a part of, like your risk is shared by, like for example, NHS, Denmark, Sweden. So these countries have their own mechanisms to share the risk pooling. And voluntary, there is no legal obligation to join a scheme like a private insurance. So the risk pooling is done by different ways, that is compulsory, automatic, and voluntary. Who is purchasing these services? So here, whatever you can say, providing the services, the hospitals, who is providing the services? Hospitals are providing the services, right? Hospitals or primary health center or community health center, or the tertiary hospital, secondary hospital, government, private, they are the providers. So who is purchasing these services, considering we can take it as a consumable thing. Health is a consumability, or health service as a economic thing, like a thing, pen. You need a pen, you go to a shop. What is a shop? It's a hospital. Who is buying things for you, for your health? Ministry of Health, that is for all over India. For social security agencies, who provides you like employment service schemes, or like central government health service schemes, or district health board, or insurance organizations or individual or household, or you also buying out of your pocket. That is called as out of pocket payment. So you are purchasing a service from a provider. So this will be the nutshell of this. So you are an employer or you are a consumer, you are paying a tax, and that can be goes to social health insurance. On from your general tax, you are purchasing from your service from a health provider, that means a hospital, and private health insurance, or you pay from out of your pocket. Out of pocket, you alone, you paying for it. You are paying a service from Jubilee or government service or from Aster. So you are directly paying, that is out of pocket expenditure. Or you are paying towards a social health insurance, such as you are paying a premium out of your like your ESI, or you are buying a private health insurance like as ICICI Prudential or something as Reliance or Max Apollo or Star Health. You are paying that, and that agencies give for buy for from the purchase from the health providers such as private or government. So this is the general mechanism. How can you track of health financing, the information on health financing? It's from by you can follow national and state budget, or you can, sir, there is called pets, we call it as pets. This is not your way of dealing it, but if you want to follow this, you have to follow public health expenditure, public expenditure tracking surveys, or public expenditure reviews. Or you can follow OECD, that is Organization for Economic Cooperation and Development. Insurance companies, third party payer, they will have their own data. Living standard measurement surveys such as household surveys, you can say NHFS recently has done a survey. And national health accounts, this is also a newly made mechanism by the government for how much fund is utilized, for whom it is utilized, and how efficient it is utilized. So how can we, what is the core indicators of health system financing? So we can say total health expenditure, THE, that we call as THE. The numerator will be the sum of all health expenditures. Denominator will be total population. So how it is divided for person, how much it is divided. So how the expenditure is shared between the population. That is one indicator. Another is the ratio of household out-of-pocket payments for health to total health expenditure. So numerator will be household out-of-pocket expenditure. You go to a house and you will ask how much you have spent for your treatment for diabetes for past 1 year, and what is your income, and out of that how much amount has been shared. That can be given as the core indicator. So health system financing in brief, it will be like we have seen the objective. First one is raising sufficient funds for health. So what will be the output indicator? Data on total health expenditure. And then data source will be national health accounts, and your associated outcome indicators will be total health expenditure, as I told before, or government health expenditure as a person. How much percentage of total government expenditure is given for health expenditure. Or the third one is total health expenditure as how much percentage of GDP. That is also valid. You can assess how much government is spending on the health expenditure. On second, it was like improvement of financial risk protection and coverage for vulnerable groups, that is risk pooling, how the government is doing it or the people are doing it. So you can say the patient or household out-of-pocket expenditure of assessing or obtaining services collected intermittently. That means for a 12 months. If it is a country like not in India, but in a countries like with the health insurance, number or percentage of people or households covered by health insurance by population group, and specifically for poor or vulnerable groups, how many of them are insured, or how many of the expenses out of the total expenditure. So the data source can be household expenditure and utilization surveys, as I told before. My the research is thesis on household survey. So you go to one home by home and ask them how much they have spent. That is household expenditure surveys, or how much how much utilization you need. Anyone is asking me a question, or should I continue?
Sir, you can continue. I think that was a mistake.
Okay. So OOP, that is called out of pocket expenditure, as percentage of, as I told, total health expenditure. We can say it used as OOP means out of pocket payments as total health expenditure. How much of percentage of that, or how much of households impoverished annually by OOPs, by expenditure quintile. How many households have been pushed towards impoverishment or poverty due to this due to this health expenditure. So third is the improvement in the efficiency of resource utilization. How they have improved, how much improvement can they bring? How can we know that? Information on government health expenditure on wages and salaries readily available, or availability of data on government expenditure on priority problems by level of government, whether they are, now we can check for how much amount the government spent on COVID, the vaccination, how much amount they are spending, so we can know how efficiently the managed, and the data source will be government expenditure accounts, and associate outcome is government expenditure on wages and salaries as percentage of government health expenditure. How much of government expenditure is gone as wages to doctors, nurses, ASHA workers, everything. So the fourth objectives will be improved financial transparency and management operation levels. So whether government has achieved that criteria, whether government have achieved a particular criteria, we can assess on that. We have an audit office for that. So these all are the, generally, if we are saying the concept of health financing, healthcare financing. So when we come to the timeline, what have we done? So I'm becoming more regarding the Indian context. So board committee started with, so initially it was like we need primary health centers, sub centers, we should cater health to the population. We may think that government has started these insurance programs very recently. It's not like that. Government started from 1952 ESI program, then central government health schemes in CGHS in 1954, and started with fifth year plan. 1970 they started minimum needs program. Then 1980 it became health for all, Alma Ata declaration. Then comes the horizontal, then linkage between an aggressive management of improve the health care of India. Then 1983, first national health policy since the independence came, that is in 1983, universal comprehensive, that was theme. So entirely for the primary health care. Then brings the 1990 basic minimum program, minimum needs program, minimum service program. Then comes in 2000, that is Janasri Bima Yojana. So government has started a new scheme, insurance scheme. So we may think that we need a government to spend more on infrastructure, while we say that government has started spending on insurance from a long back, from 1952. Then 2003 Aam Aadmi Bima Yojana. 2005 they have an integration of all the services under National Rural Health Mission. Then 2008 Rashtriya Swasthya Bima Yojana. And December 2012 they bought universal health coverage as the 12th 5-year plan. And 2013 they have included National Urban Health Mission. Then comes in 2015 Nidhi Aayog. Nidhi means National Institute for Transformation of India, that is Nidhi Aayog. So they brought in 2017 National Health Policy, that is a crucial change in India's stance on the healthcare, from provider of healthcare as such, government building the institutions, health systems. From that, from government has changed a stance towards health insurance provider. So this is a big change. You should have noticed, because government is slowly coming back of investments in the health infrastructures. So, so then comes into Aayushman Bharath Pradhan Mantri Jan Arogya Yojana. So this is a nutshell of the financial healthcare financing timeline. So and I come to out-of-pocket payments. What do you mean by out-of-pocket payments? Are the direct payments made by individuals to healthcare providers at time of service use. That means you buy, you go to doctor, you pay the money for the consultation, for the drugs, for the bed, for the treatment, for the gloves, everything. That is called as from your own pocket, from your own deposit, savings account, salary account, your family account, or your income, whatever. So this excludes any prepayment you have done for health services such as insurance premiums or community insurance premiums that you have paid. That is not included here. That is not, you are paying for your health, but it is not included in the out-of-pocket payment. Out-of-pocket means at the time of your service. So what do you mean by catastrophic health expenditure? Whenever the health expenditure is equal or exceeding 40% of households' non-subsistence income, it is considered catastrophic health expenditure. You may ask, what is non-subsistence income? So subsistence need means a minimum requirement for household to maintain a basic life needs in a society. Means you need a shelter, you need clothes, you need food. So for all that, you need some money. That is that we call poverty line income, defined based on a country needs. It may be different from one country to another country. So uh, you define on that, and you have a subsistence income. That means you need minimum income for sustenance or sustaining your life of your family, of your individual and a family. Then out of other account, that is non-subsistence income, is the remaining money after basic needs have been met. That is total household incomes plus your poverty line, that your income for basic needs. So out of that non-subsistence income, that means which you pay for film, you pay for your functions or your parties, out of that 40 percentage, if it exceeds 40 percentage of your non-subsistence income, that is called catastrophic health expenditure. Impact of out-of-pocket payments in India. Population of India with household expenditure on health greater than 10% of total household expenditure. That is 17 or 18% of Indian population. That means if there are 1 lakh people, that is, if you are considering 1 lakh people or 1,000 people or 1 lakh people, that means 18,000 will pay out of 10 percentage, more than 10 percentage of their household expenditure on health. Population of India which spend more than 25 percentage of total householding. If you have a accident at home with a non-communicable disease burden or with a communicable hospital admission, surgeries, it means 25 percentage of your total household income will be spent on hospitals or healthcare. That is included in the out-of-pocket payments. Every year due to this out-of-pocket payment. So it is a major issue here. How can we minimize these out-of-pocket payments? Either you can abolish user fee. These are recommended by WHO. These user fees and charges in public health facilities, public health, not private health. You can public health facilities, user fees, charges can be avoided. And you have to find out how to fund that user fees. That is a different question here. We will continue later. And second is target and exempt specific population groups such as poor, vulnerable, pregnant women, children from official payments. They know from the payment of for their health care. And for third is for certain health services like maternal services, or you can say child health services or mental health services. So this can be excluded. Those type of charges can be excluded, which the government is trying to do. So national, we come to a very important thing is national health policy, that is 17th National Health Policy 2017, then issued a National Health Policy, the latest one, that regarding what is the relevant points regarding to the financing, healthcare financing, that's what I'm talking about. 2/3 of the health resources for the primary care. And there is, previously I mentioned about health account system for how efficiently they utilizing the money for the national health account system. Higher allocation will be for difficult and vulnerable areas, and existing government finance health insurance schemes to cover secondary. There was earlier only primary, now it covers secondary and tertiary care services, and multi-stakeholder institutional mechanism for need-based purchasing of secondary and tertiary healthcare services. And we can use CSR. We call it in a pet name as CSR, corporate social responsibility, that is payment by Adani, Ambani, Birla, Tata, whoever, for filling health infrastructure gaps, and the collaboration with not-profit organizations for primary care services. So these all are the importance of national important points regarding the healthcare finance from National Health Policy. So now the government has introduced national health protection schemes called as Aayushman Bharath. It is the world's largest non-contributory government-sponsored health insurance schemes, which can be compared to Obamacare. Obamacare is nearly 23 million when the beneficiaries, it is here 0.5 billion beneficiaries. So it is a big scheme, and the beneficiary identification as per socio-economic census last done in 2011. And there is an other linkage for that, and 5 lakhs for family floater cap, and premium to be borne by 60% by sender, 40% by the state, and additional source by 1% cess on the toll, and new institutional structures such as National Health Agency, State Health Agency, both public and private hospitals to be empaneled. Earlier it was only public, and insurance was given selectively for public. Now it is both public and private hospitals, and focusing on the most vulnerable population. So there is a paradigm shift towards output-based strategic purchasing of services from private sector. So there is now government is just a purchaser for health for its citizens. Government purchase health for its vulnerable population. So merger of different government schemes, and government shifts from being a provider to payer. Payer in the sense premium payer. The 5 billion, 500 million people, their premium is paid by government. So we come to next important part, health insurance. We saw about out-of-pocket payments. Now we are seeing about health insurance. It is the most complex mechanism of the healthcare financing. Revenues generated by either you are paying a premium, or employers are paying a premium, or government is paying on the behalf of the poor. And this revenue is pooled into an autonomous fund that is used specifically to finance healthcare. Limitation is demand side, that is protection from cost of healthcare mix, because you are protected. So the individual will think that I can drive fast because I can jump from a building, so I am protected. There is surgeries, I am protected. So I am protected from health. So I can drink more. I don't want to take care of my health. So that is demand side. Or he can go for I am cared for everything. So health checkup every 3 months, excessive consuming excessive amounts of healthcare. So that also can more frequent visits. And supply side limitation is provider. That means Jubilee can prescribe more than needed medications or more than needed diagnostic test. So these all can happen in supply side limitation. So what are the different types of health insurances? We will go fast into this. Social health insurances, private health insurances, community health insurances. Social health insurance, such as publicly mandated for specific groups, financed through payroll taxes in Canada, deduct a percentage of monthly salary, that is ESI, or you can say about this CGHS, salary to be paid to social insurance fund, carries through either through you can go to public or private facilities, TSI, CGHS, RSP, Aayushman Bharath. And private health insurance emerges from voluntary actions in a market where buyers are willing to pay premium. You pay a premium to insurance companies that you are when you are ill, the fund will help us to take cover of your health insurance. Over 300 products from over 30 insurers competing in the market today. So it is different types, LIC, ICICI, General Insurance Corporation, all are into this. Even government schemes are into this. National Parivar schemes, all are private, work as private health insurance. You pay premium. And community health insurance, such as mostly not for a profit prepayment plans with community control. So care is generally provided through NGOs and private facilities. The premiums are low, such as 20 to 60 per year, 60 rupees per year. There are definite collection periods where premiums are paid. So we can call it a samudayam in our places. So they pay for it. The representatives of community or volunteers from NGOs are the administrators, and this keeps the cost down. So different types. Here, first type one is Accord, MGIMS, Raha examples. The community is paying the premium to the provider or the insurer, and the care will be given to the person. That is type one. Or Dan or Yashaswini. Here, the community is paying the premium to the insurer, such as an NGO, and they will pay the fees to the provider. Whatever the fees comes, that will be paid by the NGO, and that care will be given to the person. So that is Yashaswini. And type 3, that is Baldana or Karuna Trust or Seva. The premium is paid to an NGO, and the premium is paid to a insurance company such as ICICI or you say HDFC or Reliance, and the provider is giving a care independently, and the reimbursement will come from the insurance provider. So it is there are the 3 types of community health insurance schemes in India. So when I come to the challenges, the last part of this, the challenges, nearly 73% of the country's population lives in rural areas and 26% below poverty line. So, but the most of the health infrastructure are in urban areas. And when we come to the primary health centers, the recurring cost of the PSCs, that is petrol charge or the daily wages charges or the service charges of the sweepers or class 4, all are not met. There is an underfunding of recurring cost. Although there are several inherent weaknesses in India's healthcare system itself, it is a cumbersome mechanism. One is that the government is providing central, the health is a matter of state, but the national government is devising all the national health programs, and that how the problem is not solved in a state is a different mechanism that is an issue. It means a national vector control program or national leprosy control program. The fund is devising the policy or the program all by the people and by the central government. But when it comes to state has to make it a fund for different problems. Chhattisgarh will have a different problem from Kerala, so that is an issue. And dominant private sector in India, 70% of people are catered by it. There is a lot of hospitals, but almost all those hospitals are not providing any primary health care at a free of cost, or in urban or rural areas. Almost all are catering the urban health needs. So the rural population has to move on more from one village or to a long distance. They don't have a healthcare system. Even in Kerala, we can say that they have to travel a considerable distance for getting healthcare. But in northeast states, it is more. They have to travel for hours for healthcare for their healthcare services, even for primary health services. So there is an infrastructure gaps in that. And another one is epidemiological transition has happened. That means due to the globalization or the improvement in the lifestyle, now the more the lifestyle diseases are more. We call it as double burden when it comes with COVID along with the non-communicable disease. A person with a diabetes getting a COVID is a double disease burden. So it's becoming another issue in a place of India, like low middle income countries, LMIC, like India with poor settings. So the another issue is missing millions. India doesn't have an account of everybody in India. There are a lot of if you are taking Dharavi, a slum It is only 500 acre of the land, and it has near millions of population living, and most of them are unknown to the population who all are living, especially revealed by this COVID situation. It became an epicenter of a situation, but then only the state comes to know how many people are living, and most of the people doesn't have an account system. Or in our Perumbavoor, nearly 3 to 4 lakhs of migrants are living, and nobody has a data whether they are from Bangladesh or West Bengal or they are from UP. No one knows about it. So these all are the issues, challenges faced by healthcare financing of India. So what are my recommendation? Government should be the primary insurer of the poor. That's what's happening. That is, government now giving only 5 lakhs, and we know 5 lakhs is nothing, because if you want to bring the private health providers such as Jubilee, Amala, they need money. They are not giving services for free, although they are for the poor, taking care of service with love, but still they cannot take the burden of the financial burdens on themselves. So they also need money. So the government would be an insurer of the poor. People can come out to Jubilee or Apollo, and they can buy their health services. This is like earlier India's the earlier government, that we can call it as Nehru model and Modi model, like Obama model, what they are calling. So Nehru model is like you build up institutions for the poor, and according to the experts, it is a failed system. You cannot further fund it. Although the government is spending less than 2.5% or 3% on GDP, we are complaining on that. But still, it is not easy to spend such a lot of money for infrastructure, for building up an infrastructure you need, and later this infrastructure becoming poor and it is not properly maintained. So the experts are saying the government is not able to not able to provide an infrastructure anymore. So it will be like more will be for into insurance providers. Government will come into insurance providers, become the insurance provider, and for the poor, so that a poor person who is living below the poverty line, if he gets cancer or something, he can goes to Aster, or he can goes to Apollo, equally to a rich man. This is a new vision. We don't know how much they can accomplish this, but with Aayushman Bharath, the government has changed the spectrum from a board committee report from a Nehru's time to a new revolution. But I don't know how much it is going to it be accomplished. So this is in making. We may not. This may be the first model. There will be 7 or 10 models later. We may be able to see it. But in one day, India will be able. In India, a poor can walk into Apollo or Aster and can have the surgery of their cosmetic surgeries one day. Who knows? So India should spend more on their gross domestic product, again, more 3 to 5%, but it cannot happen in a day. So it should be there. It should be progressively done, and more involvement of the private sector in primary healthcare. When I say this, I can say the examples of Jubilee. Jubilee is doing a good work at Nartra. It should be given more power. It should be recognized. It should be or Angandur. It should be recognized as an equally good service provider as a government primary health center or sub center, so that the private players can come into this only if the government is providing the insurance. But still, there is a chance, there is a scope for that the government can pay for the provider, and the government, the private players, stakeholders can start their primary health centers or in remote areas, uh, which can be termed as their catchment area too. In Tamil Nadu, they are doing, some hospitals are taking care of their primary health center. In Karnataka, in Mangalore, there are 3 or 4, one CHC or 2 or 3 primary health centers are taken care by the Kasturba Medical College, and their staff and government. Even the district hospital is taken care by Kasturba Medical College. Therefore, providing the salary, funds, wages, and they are improving the building. So, and what will be the part of government? The government will be an independent mechanisms to whether there is an over utilization of health services, or there is missing persons in the, whether any providers are uh, not allowing anyone to access the health services. So government can be an independent mechanism, a ranker or a ranking authority or a check authority like a SEBI, that which controls the stock exchange, watching everyone. So that can be done, become India government can be that part, and the provider of the premium towards the poor. And we can diversion of corporate social funds to build more infrastructure. Joy Alucas can build, Jos Alucas can build. So insurance schemes can provide the providers, and government can be the insurance premium payer for the poor. And this the Birla, Adani, Ambani, or Joy Alucas, whoever, they can pay for, they can build the infrastructure, so the infrastructure can be met, gap can be met. So that's all about my if you want to do I think you are not much interested in bibliography. So that's all about me, and I am on once more I thank Niranjana, especially you brought up this idea, and this is my first webinar ever in my life. And Niranjana and Anusha, I'm very proud of you. We have now a research committee, and you are publishing in some certain articles. And I have never done published in any, I have one publication, thanks to Roni sir for that. But still, I have when I come for the research, I think I should have been into research like you when I was in undergraduate days. So I'm admire your passion. So this is Jubilee is becoming great. One day I think this is going to be Jubilee is going to be one of fine institutions like Kasturba Medical College, or maybe All India Institute of Medical Science, and we may be the proud members of that college. So all of you, thanks for watching me, hear me. I know it's a bit difficult topic. I don't know how much I have catered to your needs. Always some says that always a presenter should be at the service of the audience. I don't know how much I have served you, but I have tried my best. And a little bit political, always I am political. Here everyone, my teachers also say I'm political. Whenever I say something, I'm political. I don't know, being a Kerala Malayali, it's always political. So I will go for questions, and I will go for your ideas on that.
Thank you, sir. That was an enlightening session. Sir, we have some questions in the chat box.
Yeah.
First one by Mahadevan of 17th batch. Is there something known as disease-specific medical financing? Disease-specific medical financing.
Let me see. I'm not sure about that. Disease specific. Who asked that?
Mahadevan of 17th batch.
Okay, Mahadevan, I have disease specific. I'm not seeing that. Can you?
Disease-specific medical financing. Is there something known as disease-specific medical financing?
We are doing that. I'm not sure about in Indian situation it is there, but in he may be mentioning about how much we spend on NCDs, how much non-communicable disease, how much amount is that? Mahadevan, can you hear me? Mahadevan is here. He asked and went. Or
hello.
Mahadevan, is that you mentioning about?
Yes, sir. He says that he can hear you.
Yeah, I saw that. And are you mentioning whether there is a fund for, or do you have any other data on that? I have not heard about that, but I will check into that. Disease specific. That is interesting topic. There will maybe how much you spend on diabetes, how much we are doing on the like that on NCD. My management is like, yeah, you can type. Yeah, I'm thinking like now my research topic is on NCDs, non-communicable disease, how much a household spend on NCDs, whether they can spend on households, and how much of them are impoverished, or how much of whether that is a catastrophic spending. So there is a study going on like that, not nationally and internationally. So I'm also taking part in that. If he is mentioning that, there is definitely that term will be there if he's mentioning that.
Sir,
So
by the time
and what are
Okay. Same thing. He's saying the same thing.
Okay,
Sir,
okay.
then we'll go to the next question, sir. While he's
Yeah.
typing the question. Yeah. Ashwin
Why is,
Berkey is asking a question.
yeah. Why is cost of treatment in India
Yeah.
less than in some other
Some other
developed
country.
countries? Like you say, yeah, man, I understood your, I understood your intent. I understood why why you asked that question. India, because our uh, infrastructure is funded by government, and one thing is infrastructure, and our doctors' salaries are paid by the government. That's true. That's true. But the population is increasing, and how long India can spend on health, and how much is enough, and people are more educated. Do you think a man goes now to a government and are satisfied, saying that this is enough? It was in olden days. Now they need more care. They need excellent care. They need they're asking for more. The services they're asking are like not just get what you need. If you're going in a rural Karnataka, so you can see people takes whatever they get, but not anymore in Kerala. Kerala, they will ask for even the medicines. They don't like the medicines what they get at a hospital. They have government tried to reduce the cost by Jan Aushadhi, but still the cost is, they want a better medicines. They say like that. And even in vaccines, people are thinking whether which vaccine is better or not. You can you imagine in past 20 years before, India may not be like that, but now in Kerala, if you are taking Kerala in the future of India, and after 10 years or 20 years, government will not be able to provide the services in at a level of satisfaction. Is it clear for you, Ashwin?
Yes, sir. Yes, sir.
Thank you, man. Thank you. It was a nice question. I understood.
Sir, I have a question. You said India
Yeah.
has a out-of-pocket model. Yes, it's
Yeah.
the microcosm of the entire model. But what model should India look up to, or in future, do you think, according to you, what model India should look up to or adapt to? Beverage model, Douglas?
Like in the sense Douglas model in the sense, the insurance will be paid by the government for the people. Citizens pays a premium, government pay premium, and the providers should be private, like Apollo
Okay.
or Jubilee, Amala, and government should entirely take care, should give, or what they're going to do. Have you heard the public-private partnership? People say in Kerala they are going to sell our government colleges, but that's a plan. That's a plan of Niti Aayog. That is, the government hospitals will be sold, and government will be entirely towards premium, paying a premium for its entire population. So the people can go wherever they want, whether and the hospitals will be ranked as we rank our institutions, which hospital is better or not. So that is going to be the model, as I think. But it is not a foolproof system. It will have its own problems. There will be, as Ashwin mentioned, there will be an escalation of prices, cost, because people are providing services, private services, private players are not for help, but they are for profit. So they need profit. They'll make more profit. So this, how the government is going to control it, it is a different question. But I think government is going for towards Douglas model.
Okay, sir. Thank you.